Welcome everyone to the latest installment of EMS Focus, a collaborative webinar series. My name is Max Severat. I'm an emergency medical service specialist with the National Highway Traffic Safety Administration. I work in the NHTSA Office of EMS. Together with our federal partners, NHTSA's Office of EMS is focused on advancing a national vision for EMS. The projects we undertake and the resulting resources for the community help with systems improvements, measuring the health of EMS systems nationwide, and delivering the data that EMS leaders need to advance their individual systems. Another role of the Office of EMS is to educate the EMS community on things like new innovations, processes, and technologies that can, in the end, help provide better and more efficient patient care. This free webinar series that you're attended, hosted by our NHTSA Office of EMS, is a unique opportunity for federal EMS agencies and industry experts to share information with the EMS community. EMS Focus conducts webinars several times throughout the year on issues that are important to the EMS community and provides you with timely information on what federal agencies and others are doing to address these kinds of issues. Today's webinar is also being recorded, so it'll be archived on ems.gov for future viewing. There will be time at the end of today's webinar for questions, but please feel free to type questions or comments using the chat feature during this webinar. More information on the EMS Focus webinar series can be found on ems.gov. Every day, EMS clinicians work hard to provide the best care for their patients. But how do we know if the system is consistently delivering evidence-based care and achieving desired outcomes? One way is through the use of performance measures. Measurement is key to knowing how we're doing and whether intended improvements are working. This is critical to achieving the safe and effective people-centered EMS system envisioned in EMS Agenda 2050. Performance measurement is part of a continuous cycle of improving patient care that it includes collection of standardized EMS data made possible by a number of things: state EMS data systems, the National EMS Information System, or NEMSIS, the creation of evidence-based guidelines, a topic we actually recently covered in a previous EMS Focus webinar, which is now available also on ems.gov, and the implementation and evaluation of interventions and investments based on those guidelines and other research and innovations. For today's webinar, our panelists will be discussing ongoing efforts at the national level to support performance measures and improvements in local and regional as well as state EMS systems. You'll learn about the latest activities of the National EMS Quality Alliance, or NEMSQA, a recently formed organization spearheading the development of standardized measures using NEMSIS data. We'll talk about how the first set of measures was developed and tested and how your system can use those measures to evaluate and benchmark performance. And you'll also hear what is planned for NEMSQA in the future and how you can become involved in measuring performance. We've got a great lineup of speakers today joining us to discuss this important topic. First, you'll hear from Dr. Michael Redlener. Michael is the Medical Director for EMS Quality at Mount Sinai Hospitals in New York and completed an EMS fellowship with the New York City Fire Department. He's the co-director for the National Association of EMS Physicians, EMS Quality, and is also the Vice President of the Board of the National EMS Quality Alliance, NEMSQA. Our second panelist is Dr. Jeff Jarvis. Jeff is the Medical Director for Williamson County EMS and Marble Falls area EMS outside of Austin, Texas. He began his career as a paramedic, an EMS educator, and continues now to maintain his paramedic certification. Jeff represents the American College of Emergency Physicians on the NEMSQA Steering Committee and is also the host of the EMS Lighthouse Project podcast. Lastly, you'll hear from Brooke Burton. Brooke is the Division Chief of Quality for Falk Ambulance in Alameda County, California. She's a member of the Board of Directors of the National EMS Management Association, which she represents on the NEMSQA Steering Committee. Brooke is also chair of NEMSQA's Communications Committee. And then finally, you'll hear from me, Max, your host for the webinar today. So first, Dr. Redlener, I'll turn it over to you.
Thank you, Max, and thank you to a lot of people who have helped to make this effort successful. I'd like to just say thanks to NAEMSP for supporting my efforts at NEMSQA, to Kelly Burleson and the team at ASAP who have given us the resources to really get this thing going. So I really appreciate the opportunity to talk today, and I'm going to start off by talking about my own personal experience and what drives my interest and my appreciation of this project. So I finished my EMS fellowship in 2012. It was an amazing opportunity. I had the opportunity to hang off the side of buildings. I had the opportunity to do trench rescue. I had the opportunity to be a part of the largest EMS system in the country. When I finished the fellowship, I took a job as an EMS medical director in New York City at one of our hospital-based agencies, what is now Mount Sinai. And I was very lucky to get that position. I was excited to be a medical director. And then when I got there, I started thinking, well, what does it mean to be a medical director? How do I know that our ambulance service is doing a good job at taking care of patients? How do I know in general that we're doing a good job? So I started looking around, and I started thinking about how we can best do this. So next slide, please. So to be fair, we're transitioning from written records to electronic PCRs. But I have to say that the way that we were looking at quality was very reactive. We would hear about an error. We would try to correct that error, usually through discipline or on-the-spot education. Brooke will be talking a little bit more about modern quality improvement methodology, but to say, I just wanted something to assess how we were doing as a service. And data that was really, I was looking for data that was important to our patients. So I began looking around. If you go to the next slide. So I began looking around really, and as a member of NEMSP from the time of my fellowship, I found that was the most natural place to look. I went to the Quality Improvement Committee. I looked around, I listened to what people were measuring, and then I spread out our searches about where we could look for clinical quality measures that were important to patients and that were evidence-based, that would be powerful in kind of giving myself and my colleagues a sense of how we were doing to take care of our patients. So you see around on the slide that there were a number of places that were doing this work. It just never seemed to be all captured in the same place or accessible to my colleagues in the EMS medical director world. So when I found out about EMS Compass, this was just about the time that EMS Compass was coming together and that NHTSA was supporting the original EMS Compass project. And I, as you see by the bullets on the slide here, there was a tremendous amount of work done by the EMS Compass group to identify important measures in EMS. There was 14 candidate measures that were released in 2016 after a long process of identification of specific measures. And I can tell you from doing the research as we were starting NEMSQA that there's a tremendous amount of work behind the scenes that went into developing those 14 candidate measures, including the measures specification, the NEMSIS pseudocode, and EPCR vendor readiness project deliverables. So, you know, that project was an incredible project that was a very important start to this. As it happened, the measures were released and approved, but they didn't seem to gain traction. So in 2017, NHTSA again turned to the EMS community. If you go to the next slide, they awarded the American College of Emergency Physicians a contract to continue to work on EMS performance measures, EMS quality measures. And this is what would eventually become the National EMS Quality Alliance, or NEMSQA. And so this was formed in 2018 under the NHTSA contract. And the first project of NEMSQA was really to take the EMS Compass measure set and look at it again and identify the measures that were relevant and feasible for the EMS community to look to really identify a very high quality level of a performance measure. So the organization became a 501c6 in 2019, and essentially, as we go to the next slide, it's the way that I see it, and I think a lot of the board sees it, is that NEMSQA is really building on all of the foundations that EMS Compass put down for this project of building EMS quality measures that are meaningful to the EMS community and to the patients that we serve. On the next slide, you'll see that there's our stated vision and mission. So improving patient outcomes through the collaborative development of quality measures for EMS and health systems of care is our vision. And our mission really is to develop and endorse evidence-based quality measures for EMS and healthcare partners that improve the experience and outcomes of patients and care providers. Now, these are focused statements, but if you break them down into their pieces, you see that a couple of the things that we felt were important. One is collaborative, making sure that it was an inclusive process. And we use healthcare systems a lot because we know that EMS does not stand alone, and that we will be working with many of our partners, be it the AHA, with CARES, with other folks in the industry who are looking at elements of EMS quality. So, and with that focus on the patients and our care providers as really the focus of our efforts. So go to the next slide. So NEMSQA Steering Committee are the organizations that have primary contact with the providers who are providing patient care. And so this group of organizations from across the EMS spectrum are involved as the steering committee. And then if you go to the next slide, the other partner agencies that are listed here are membership organizations. And from these two sets of organizations, our board is selected. So there are a number of board members from the stakeholder group and a number of board members who are elected from the steering committee. And so if you go to the next slide, if you were to see the structure of how NEMSQA is organized, you would see that this community of organizations sits atop the board of trustees that then go into the different functions and different structures of our organization of NEMSQA. So on this slide, this is one of the key slides of the presentation. And what you'll see here is our approach to measure development. This approach is inspired by the NQF process, the National Quality Forum process, which is responsible for stewarding measures throughout the healthcare community. And if you go from the top, the identification and prioritization of new measures is a box into itself, identifying things that are important to the EMS community and to our patients. Now, if there's already existing measures, you go down another pathway to partner with those organizations. If there are no measures in the areas that you want to measure, then you take it into the measure development life cycle. And that's essentially what we did with the EMS Compass measures. And then through these three processes, research, making sure that measures are evidence-based, specification, making sure that they are valid and able to be measured in NEMSIS or in the electronic medical record in general, and then testing and learning, which takes us through actually putting these measures through a process where we understand how they come through the actual specifications of the measures and how they relate to real data. My colleague Jeff Jarvis will be talking about this more in detail as we go. Then the final lines on the bottom are really committee and board approval, measure development, and then big data testing in the real world, as well as potentially endorsement and licensing opportunities. So it's a really a robust process, and we hope to make it as clear and as open as possible, so that that folks that are like folks on this webinar really have an opportunity to see behind the scenes what we're doing. So this is what we did with the EMS Compass measures. So if you go to the next slide, we took the 14 EMS Compass measures. We put them through this rigorous cycle with multiple meetings, both in person and online, to develop these measures that were that came from the best evidence, or the most important from the point of view of the EMS community. We made sure that they were doable, and we made sure that they bore out in terms of the testing and learning phase. So on the right-hand side, it's the NEMS, we call it the EMS Compass 2.0, or the NEMSQA quality measures. So if you go to the next page, you'll see that there's essentially 5 areas that are selected. We wanted to create a broad range, actually it's EMS Compass and are building on them, that we wanted to create a broad range of measures that were important to our patients. So measuring hypoglycemia, looking at stroke-related measures and seizure-related measures, so neurology. We wanted to look at pediatrics. We thought that was important, trauma, and of course, safety, which is an important thing across the country. So if you go to the next page, I'm going to go briefly through some of the reasons why there are 3 less measures from the original EMS Compass set. So first, seizure 01. This was a measure to look at the rate of glucose, finger stick glucose measured in seizure patients. Now, over the course of the last 2 years, there's been some literature that has come out that suggests that checking finger stick blood glucose in patients who are having a seizure may not be the first thing that we need to do when treating seizure patients. So we decided that would not be a good measure to start with if there's contradictory evidence. So seizure 01 came out, and likewise for stroke 08. Stroke 08 was a measure of timeliness of treatment from arrival of ambulance to treatment in the hospital. And this required hospital data in order to calculate. And so we felt that it's not fair for many agencies across the country. We know this through both probably just common knowledge of all EMS, and secondarily through national surveys. Access to hospital data is not that easy for every EMS service. So we took that out as well. We also took out a trauma measure that was what we felt to be redundant. So we are left with the set of measures that was just presented in the slide prior. If you go to the next slide, you'll see that this is another way that we felt we improved some of these measures, right? And again, Dr. Jarvis will go through many of the specifics about some of the measures, but here I just am showing you that we updated many of the denominators, the numerators of our measures, and the definitions of our measures in general, just to make sure we were capturing the population of people that we were interested in. So how do you decide if somebody's hypoglycemic, right? And that they're symptomatically hypoglycemic. So you have to look at it both from the documentation of altered mental status and then identifying somebody who's like hypoglycemic. And then you have to also look at the patients who are, the primary impression of hypoglycemia, and then look for altered mental status in their PCR. So and then we excluded patients who are less than 24 hours old because hypoglycemia is a different number for newborn infants. So that's the kind of thing that we did, and we spent many hours talking about many different measures. So there was a lot of work that went into trying to make this as usable as possible. So if we go on to the next slide, I'll direct you to the NEMSQA website. there is a tremendous amount of work that's available for you to see. If you are somebody who's implementing these in your system, there should be all of the information that you need to input this into your system. If you're an EPCR vendor, you should be very familiar with how to build these within your system. And I would encourage any EPCR vendors out there to make sure that they've got this in their available resources for agencies that use them. So, and again, Jeff Jarvis will be talking and speaking about these some of these elements in a little while. But I'm just going to say, if you go to the next slide, I would say that there's a big picture thing that I just want to mention briefly, right? This is, yes, we have all the specifications, as you see on the left-hand side, but I think that also what's important is that we have the stories of why they're important, why we made the decisions we did. And so it's not just a fairy tale, but it's something that we think is important to tell the story of why these are important. So that you'll find all of that on the NEMSQA website. So next slide. So as we roll out, and this webinar is part of this process, we are going to be rolling out, speaking at conferences, familiarizing the community with what is available. Again, I mentioned the website. We want to talk about what NEMSQA partners are implementing. And then we want you to know that we're going to be looking at these every year. Sometimes we're not going to have the exact right information. I'm sure as soon as people start to use them, we'll get more and more information about why one thing is correct and the other thing is not. But we want to be open to that and grow these measures as our understanding of them grows. And so we also want to ensure that, if new evidence comes out, we don't want to use a measure that is not evidence-based or goes against current problems with measures that don't reflect the best practice and best care for patients. So if you go to the next slide, again, this slide is just to remind everyone, and probably no one needs reminder, but that EMS is a diverse practice across the country. And we know that care in some places may be of higher quality in other places. And so setting in national measures and looking at benchmarks, which Dr. Jarvis will be speaking about, is an important process for all of us. And we want to know that wherever you are in the country, that if you're a patient, you're receiving the best care. If you're a provider, you're providing the best care that you can. So that's one aspect of why national measures are important. If you go to the next slide, this slide is to say that we are working very much in conjunction with our evidence-based guidelines colleagues to look at the highest quality evidence in EMS and use those as the basis for new measure development. So we want to stick to this, make sure that the community knows that we're working with them to make sure that the quality measures that we choose are in line with the highest level of evidence that we've got. Next slide. So the last point that I'll make is that we know that data can be dirty. We're not going to have perfect data. There's no such thing. And so what this project enables is a practice across the country of benchmarking, which we'll talk about in just a minute, and I'll turn it over to Dr. Jarvis at that point. But we're not going to get to perfect data. We understand that there's going to be some level of imperfection. We know that EMS are not professional documenters. They're professional folks who are taking care of patients. And documentation, although it's very, very important, it's never going to be perfect. So we want to get to the best point where we're, looking at the best data that we've got and using it for good purpose to measure the things that we think are important. So with that, I thank NHTSA, I thank the folks at Red Flash who have helped to put this on, and I'll turn it over to my colleague, Dr. Jeff Jarvis.
Thanks, Michael, for talking about your pathway to the measures, EMS Compass and NEMSQA, and refining of measures. And now I'll turn it over to Dr. Jeff Jarvis, who will talk next about testing the NEMSQA measures using actual EMS data.
Perfect. Thanks, Max, and thank you, Michael. So I wanted to just start by going back to something Michael was just talking about there, where he was talking about data. And one of my favorite phrases now, talking about improvement efforts or research, is that you can't start an improvement effort with the data that you would like to have. You have to start it with the data that you have. And that's where we are right now. So not only do these measures help us facilitate improvement within our systems, but we're also going to be facilitating improvement of the measures themselves. So that's the key thing we want to do here. This is all about improvement. So what I want to talk to y'all about is how we tested these measures, how each agency can calculate their measures within their own system, and then how states or EMR vendors might use those measures to facilitate benchmarking. So basically for our testing committee, what we did was reached out to NEMSIS as well as several EMR vendors, and we said, help us test these measures. So by this time, we had the formal definitions of each measure, and what you see up on the screen right now is from a document called the measurement worksheet. So each one of the measures has a form like this, and what we're looking at is just a screenshot of one part of one measure. And as you look at this, what you'll see, the key parts of this are the numerator and denominator. And each one of these measures is a proportion. So it's a proportion of some type of call and some type of patient who receives some type of care. And what I'm going to do is just give you some examples here and walk us through how we tested these, what the results were, and then how we can look at these results to improve our performance through benchmarking. All right, so for this measure, we were looking at how often pediatric patients are getting an estimated weight. And the denominator for this that you can see right there is all EMS responses coming from a 911 call. So this is going to exclude interfacility transfers. And we're only looking at patients that are less than, I'm sorry, can you go back to that real quick? Less than 18 and who received a weight-based medication. So that's in the denominator, the bottom part of the ratio. And if you, as we go down a little bit within this thing, and I only included part of it because if you put the entire thing on there, nobody can see it. But it would give you some ideas about what weight-based medications were. So for example, albuterol is not a weight-based medication, so that would be excluded. So if you have say a 10-year-old who their mom called 911 and they got albuterol, that would not be included in the bottom number. And then the top number is just, did they have a documented weight or an idea of what their length-based weight was, something like a Broslow system. Okay, let's go to the next slide. And this is just a summary of what we're looking at in ratio format. So again, we're looking, first we create our bucket of data, and in this bucket, we're putting 911 calls for a child less than 18 who got a weight-based medication. And within that bucket, we want to see how many patients had a documented weight. And that's what our proportion is. So can you go to the next slide? And this is the results of this. And I just want to share a couple of measures here. So the data set that I was working in is the ESO research data set. So this is a bunch of anonymous data. So I have no idea who the agencies are, and I obviously have no idea who the patients are. And it's of agencies that have consented to have their data used for research purposes. So in this particular measure, when I filtered out 911 calls, weight-based med, and under 18, I ended up with 36,000 patients that were treated by 917 different EMS agencies. Now, for each one of the measures, each data set would calculate these particular data elements. So I'd like to go over those if I can. So the max performance, and this is overall, not by agency, but of all these 917, the highest performance was 100%, and that's not shocking. You're going to see that with every measure. The lowest was 0. Again, not surprising. But the thing we really wanted to look at is the median. So the median is the 50th percentile point. So that is the point, and in this measure is 86%. What that means is that 50% of agencies reported less than 86%, and 50% reported data above that. And then you can see the same thing there with Q10. That's the 10th percentile, or the Q stands for quartile. The 10th quartile means the same thing. 10% of agencies had less than 0% compliance for this measure. Obviously, you can't have less than 0, so it's just 0. The 25th quartile means 25% of agencies performed lower than 39%. 75th percentile, 90th percentile, you can see there. The one thing I would like to point out is the distinction between mean and median. When we talk about means, we frequently, or when we talk about measures, we'll typically talk about, well, the average performance across agencies is this. Well, that's probably not the best marker to use because averages can be pretty heavily weighted by outliers. And if you look at this, you see a lot of agencies did very poorly on it. So that's going to pull the average down. A better indicator of where the middle point is the median. Now, if we want to see, so that's how this measure performed, but if we want a graphic look, and a lot of us are graphical type folks, take a look at this diagram to the right. So what we're looking at here is on the y-axis is performance with this measure. And the dotted line across the top corresponds with 86%. So that's the median for all agencies on how well they performed. And then what you're seeing is 917 different dots along this plot. And some of the dots are red, some are blue, and some are green. And the red ones mean that their performance is under the median. Blue means that you're at the median, and green means you're above the median. And our definition for what below, at, and above is that if your entire confidence interval, so a confidence interval, in this case a 95% confidence interval, says what's essentially your margin of error. And the more calls you have, the tighter your confidence interval is going to be. But if your entire margin of error or confidence interval is below the median, then you get a red dot, and you don't want a red dot. If your confidence interval crosses that median for the national performance, then you are performing essentially at the overall national performance, and then green means you're better. The reason we have a straight line at 0 and 100 is just an artifact of the data. So where you can use this, let's say that you are a state agency, or your NEMSIS, or you are an EMR vendor, you can generate a plot like this for all agencies. And then you as an individual agency can look, and your agency will be identified to you only. Everything else would be blind. So you wouldn't know who the agency to the right or left of you is. You wouldn't know who's performing best or worst, but you would have an idea how you're performing, and visually you could compare it to how other agencies like you are performing. So that's an idea about what we're looking at. Now we're just going to go through a couple of other measures to give you an idea of how these turned out. So let's go to the next slide, please. And we'll talk about the next measure. So this is obviously a hot topic, and what we're looking at here is patients who called 911 and had a primary or secondary impression of stroke or TIA. That's the big picture generality. The actual, if you go to that measure job and then or worksheet and the specifics on it, you'll find out, well, what do we mean by stroke? And it turns out there are a lot of different possibilities for what a stroke is. So all of those got lumped together in this definition. So if you have an impression, primary or secondary, of stroke or TIA and called 911, you're in the bucket. And what we wanted to know is what proportion of that bucket had a stroke screen documented. And specifically in this case, we're looking at the specific fields for stroke screen. So let's take a look at how it performed, and we'll go to the next slide. And you can see that the median performance across all agencies was 66%. So a little bit more than half of patients with a stroke or TIA had a stroke scale documented in the appropriate place. You can see that there were a lot more of these than there were pediatric patient weight-based medication, 77,000, and as a result, there were more agencies that took care of those. So this is looking at 1,100, a little over 1,100 agencies. The average is 60% and the median is 66, so they're a lot closer on this measure. And you can see where the 25th and 75th percentile are and how we how that stuff plots out. So you can see where the high performing and low performing agencies are. And just to be clear, this was my term, the high performing and underperforming, because I kind of got stuck and couldn't come up with a better term for it. There may be a better term. We're not trying to say this is a bad agency or a good agency. It's very specific to this particular measure. And let's go to the next one. And this is an interesting one because this is a safety measure. And what we wanted to look at is all 911 responses to the scene. And we're looking at the proportion of those that did not use lights and sirens. So the reason for this is that there is good evidence that the use of lights and sirens increases collisions, it increases injuries, and it increases fatalities, both in the people in the ambulance as well as the people in the other vehicles. So we wanted to phrase this where the higher, and all of the measures are phrased like this, the higher the proportion on the measure, the better off you are. So we're actually doing an inverse of this. So we're not looking at the proportion with the lights and sirens response, because that's the dangerous part. We're looking at the proportion without a lights and sirens response. And let's take a look at how it performed. So let's go to the next slide. And you see that, wow, this is very interesting. So 50% of all agencies had less than 5% non-lights and sirens response. So another way of thinking about that is the inverse, 95%. 50% were going to the scene using lights and sirens. So that's where the median is, and you can see the distribution. So there are some agencies that are doing pretty well about going to scenes without lights and sirens. But the majority, that number, that overall median is pretty low. So that gives us an idea about where we can improve. And with that, I think we're going to turn it over to Brooke and talk about how you can use this to actually jump into some improvement efforts.
Thanks, Jeff. Now that we've seen how the measures were developed and how you can assess your organization's performance, we're going to now take a quick look at a specific example of how you can use that information to make improvements. For that, we'll turn over to Brooke Burton. Brooke?
Thank you. I was asked to speak today because I'm one of the people who are using these measures in my daily practice at my agency. So I wanted to talk with you a little bit about how I'm using those and how you can replicate that in your own practice. Also, I just want to say there's more than one way to skin a cat, as they say. So there are other techniques out there that you can utilize. If you have one that works for you, that's great. Some people use Six Sigma. Some people use IHI model for improvement. You know, there's some other ones out there as well. So this is what I personally use, but feel free to investigate and see what works for you in your agency. So when we look at doing improvement and using these performance measures, I like the IHI model for improvement. And it's pretty simple at the base of it. So there's 3 questions that we want to evaluate. What are we trying to accomplish? So what do we actually want to do for our agency or our patients? How will we know that a change is an improvement? So how are we going to look at that data, collect it, and measure it to know that we're doing better? And what changes can we make that will result in that improvement? So what are our change ideas or our things that we're going to try to improve our system? And then once we answer those 3 questions, we get all of our ideas together and we try them one at a time and do the plan, do, study, act, or PDSA cycle. So we're going to plan out how we're going to implement those changes. We're going to test out those changes. we're going to study the effects of them and see if we like the results or if we don't like the results, and then we're going to act on them. So are we going to adopt those changes? Are we going to abandon them completely? Or are we going to adjust them and just try again with something slightly different? So that's kind of the base of this performance improvement model that was developed by the Associates in Performance Improvement and is taught at the Institute for Healthcare Improvement, or the IHI. And I'm going to show you on the next slide a project that kind of talks through this. So Dr. Jarvis talked to us about the stroke exam performance measure. And this is a improvement project that was done by a system utilizing that stroke exam measure. So as you can see at the beginning on the yellow line, and one thing we want to do, just to go back a little bit, is use our data over time so that we can look and see how things are performing over the course of time. So these are called run charts or control charts. And if you don't know how to get your data out of your PCR to be able to look at it like this, then contact your PCR vendors, because pretty much all of them have reports that are built in or ways that you can build these reports and get your data out of them. And most of those vendors will also have good training programs to be able to help you to get this data and get it in a meaningful way that you can use. So at the beginning of this chart, you can see that this system was performing at around 40% for getting a stroke exam documented when a patient had an impression of stroke. And so this system knew that they needed to improve that, and they thought they would try some change ideas. And a good way to do this is to keep track of that data over time, but also to mark when you make those change ideas so that you can see how they change the chart and how they change your performance. So the first thing that was tried was a memo. So they put out a memo to all of the staff to say, you know, we need to get this documented in the right place, and here's how to do it. And as you can see, after that memo is released, the compliance actually went down. So the memo had very little to no effect on changing the performance for this measure. And then they tried a training. So a training on a learning management system, training people, and that made it, you know, no real difference in the system at all. And so in looking at different things that they could try in this system, they discovered that their PCR vendor had a way to make the stroke exam a validation in their documentation. So if they chose an impression of stroke, they wouldn't be able to close or lock the PCR without completing that exam. And so once they turned on that function in the PCR, obviously, that documentation compliance went way up for the stroke exam. So that's where you can see the big jump there where it's marked validation. And it's really interesting because you would think that if something is a validation that you would have to do it, right? So you should be at 100% after that. But as you can, you know, study your data and you see things in your system, that's how you find problems, and you see, oh, well, even though it's a validation, still isn't getting done. Why is that? And in investigating, it was found that if somebody filled out one little piece of that stroke exam, it was passing the validation, but not all the fields were complete inside the exam. And so that's why it wasn't marked as being compliant. So again, some feedback and education still has to be done on those to you know, tell the crews that they need to continue to document that. So that kind of shows you how you can use your data to visualize your system. You can do tests of change when you're trying to improve these different performance measures, and you can see how your tests of change are affecting your system based on where your data is leading you. So next slide, please. These are just a couple of additional training places that I've utilized for quality improvement. It's definitely not an all-inclusive list. There's several different things out there, but the NEMSP does a quality improvement conference, and the Institute for Healthcare Improvement, whose program I just referenced, has a lot of online resources as well. So you can tap into any of those resources to try to get more information. What I talked about is the very surface of the improvement training that they provide. So definitely look into it more if you want to get more involved and have more questions and dig deeper into those processes. So the Improvement Guide is a book I would highly recommend as well, to really take a deep dive into some of these performance improvement practices and utilizing these charts to be able to look at your different system and learn about tests of change. Okay, next slide.
Great, thanks, Brooke. Before we take questions from the audience, Michael, can you talk a little bit about what's next for the National EMS Quality Alliance?
Thanks, Max. Surely. So we have plans into the near future. NEMSQA is going to be developing future measures to improve care and outcomes in the EMS community. We'll be looking for input from this group and from all of our partners across the country. And we'll be looking for ways to and opportunities to help NEMSQA really get the resources to develop meaningful measures. More than I knew before this, I embarked on this project. It takes a lot of time, and it takes a lot of people and a lot of energy and focus to develop good quality measures that are in line with priorities in our community. So it's really important to be able to have the resources to make this happen from a technical point of view. We want to continue to build our partnerships and make improvements in the way business is done. So we hope to be making recommendations to NEMSIS about data elements that are important to capture. We want to collaborate with our technical vendors, both data vendors and EPCR vendors. And then we want to look at how to benchmark. How can agencies use the techniques that Dr. Jarvis was mentioning really to identify opportunities for improvement in their system? There's an example that I like to use from across the country. As we know, and has been documented in the literature, cardiac arrest survival rates across the country vary widely. Some systems are excellent, and some systems have a 1 to 2% survival. So that's a very clear example of how EMS systems take care of patients across the country. It's not the fault of individuals, but what are the baseline survival for cardiac arrest? How do you do improvement? How do you make improvements in a stepwise fashion to improve your region or your agency's survival rates for EMS? Obviously, there's a lot of factors and a lot of ways to make improvements, but just looking at that across the country will be helpful. And it applies to all clinical conditions. It's just most obvious with cardiac arrest. Anyhow, if you continue to the next slide, I'll stop my ranting. So if you're interested in NEMSQA, if anyone here or any agency organization is interested, we have non-member participation. So there will be available resources on our website. We have social media presence that will probably grow over time. And we'll be looking for measure concepts and public comments during our life cycle approach to measures. For those agencies or organizations that are interested in becoming part of the NEMSQA team, there is a small fee for organizations that are interested in joining the organization as a way of supporting the operating budget as we move forward. And then there's new opportunities for corporate sponsorship and corporate partnership, as well as opportunities to become involved in the activities around measure development that are going on at NEMSQA. So there's a lot. This is I would say we are learning and growing and trying to put forward this mission of developing high quality performance measures that will really impact patient care across the country. So if you could go on to the next slide. So I'll turn it over to the folks at NHTSA, to Max, and for the question and answer period.
Great. Thank you so much to the three of you. Now that we're done with the presentations, I'd like to provide a few more details for the listeners to learn more after today. To learn more about NEMSQA, please take a look over their website listed here. For more information on EMS data, you can also look on ems.gov at this link listed here. Should you have future questions after today, we've also listed our contact information, emails, Twitter handles, also at the bottom. Now, a few quick comments that we'd also like to mention. We've gotten a few comments during the webinar, but one thing we want to highlight is that people can also go to nemsis.org, where you can view reports, then public reports, version 3 dashboards, and performance measures, where the NHTSA website, the NEMSIS website, already shows you some of these sample performance measure dashboards, which you can also take a look at, documenting and showing both national and, I believe, from a state perspective, state-only specific measurements in the performance measure dashboards. It's also probably a good opportunity to reiterate that these measures are based on evidence and best practices and patient-centered focus, which means that they should be applicable in any system regardless of local policies. So one of the things we'd also like to mention is, if you've got future questions after today, feel free to send us those questions. We'd also like to open up the webinar now to take questions from the audience, so feel free to post in the online chat window, and hopefully we can get to all the questions today or get back to you with answers afterwards. One of the first questions that we got, somebody was pointing out that their agency only responds to ALS assignments, so it could be an example of how not every measure would be applicable to them, at least they shouldn't benchmark against agencies that are also BLS. At the same time, you know, ALS only agencies should have a slightly higher rate of lights and sirens response than other do, as we think back to one of the examples shown today.
Max, I would also just say to folks who are interested in using these measures in their agency that I agree with you. If your agency specifically doesn't do ALS care, then you're going to have trouble tracking some of these measures. However, if you're a state, if you're a region of a state and you want to look at the measures that, from a regional point of view, you know, if you want to think about, you know, system design or protocol changes that are evidence-based, perhaps you know, if you're not checking or if you're not treating hypoglycemia in 75% of cases, you may want to think about what your resources are in your region to treat that. Do you expand the BLS, use of glucose? Do you change the makeup of your providers? So there are some things that not only impact on an agency level, but can be viewed from the perspective of regional governance.
Great. Another question posted from a listener. It does not look like the validity and reliability data, such as inter-abstractor reliability, signal-to-noise analysis, those types of things, have been shared in this presentation. Can you provide a report on these testing processes and the results?
If I am correct, and I believe I am, that on the NEMSQA website, all of that, the validity testing should be available at the site that I showed. If you go to NEMSQA.org and you go to the measures page or section, there'll be many hyperlinks that look at the validity testing.
Similarly, will those types of measures be submitted to the National Quality Forum for its review and endorsement?
So I would say that we have not yet submitted to the National Quality Forum. As we grow and develop and mature, I think that is something that would be something we would consider.
Another question, what is NEMSQA and NHTSA's purposes in releasing these types of measures? I can start that answer from a NHTSA's perspective. You know, I think, frankly, one of our reasons for these performance measures are to challenge EMS agencies and both in state and locals to consider looking at their performance if they have not already. But maybe one of you could talk about NEMSQA's purposes in releasing these measures.
As an example, I just wanted to make a comment about that on, let's say, the red lights and sirens. So there is no objective answer that we have, no literature-based answer that says you need to be running to X proportion of your calls with lights and sirens versus not. We don't know that. There are lots of ways you can look at that particular issue. Well, what's the call nature, and are you doing some type of prioritized dispatch. But what the evidence does say is the use of lights and sirens increases the risk to everybody involved. So by having and encouraging agencies to report that data, what it does is gets them looking at the issue. And we know that less is better, less red lights and sirens response is a better thing. So that's a challenge to start looking within your system and identifying how you can safely reduce that risk.
The other thing I would say is that I think that the goal, and I can speak from the board perspective, is really to improve EMS care for our patients across the country. And, you know, some of the items that have come up in prior discussions about this and why we released these measures, and it kind of goes back to what I started with. You know, I want, and I would hope that all of my colleagues would want something to understand how we're doing. How are we doing as an EMS organization? How are we doing as EMS from a national perspective? And I want that to be, I want to give people the tools, and we want to give people the tools to address challenges in EMS care. We all deal with them, and we all need to have some way that's evidence-based, well-developed, that can be applied in most situations. So I think that this is a resource, and I would hope that instead of just going to compliance from the state level, I would hope that these measures are used to, from a quality improvement standpoint, improve the care of patients at the local level.
Great. I think we've got time for one more question with a quick response. Do any measures capture patients who were misdiagnosed pre-hospital? For example, if a patient was having a stroke but EMS missed it, maybe Dr. Jarvis, you could try that one?
Sure. That's an example of an outcome, and we would love to get those. The challenge is that kind of takes me back to my initial statement that you don't begin these efforts with the data you want, you begin them with the data that you have. And although we are starting to see some large systems where we're getting outcome data in, overall, we don't have it. So we were trying to focus in on measures of data that we have rather than what we want. So in the future, when we start having more reliable outcome data, for example, what was the ICD-10 code in the emergency department? What was the diagnosis in the emergency department? And we have that data, then we can start building those measures. But that's the big limitation for a national measure. For a system-based measure where you do have that outcome, absolutely, I think that would be a really important measure to do.
Work in progress. Thank you so much. Well, thank you, Michael, Jeff, and Brooke, for a great webinar, and thanks to all of you for tuning in to join us. As a reminder, we'll be posting the recording of this webinar to our YouTube channel, as well as ems.gov, and please join us for future editions of EMS Focus. If you haven't already, make sure to visit ems.gov, where you can sign up to receive updates about future webinars, as well as other NHTSA Office of EMS activities. Thanks, everyone, and enjoy the rest of the day.